Join me, Mike Colbert, as I host the 9th Annual PIPE Conference, October 23 and 24 in Edmonton. PIPE is Alberta's largest primary care CV event. We have a fantastic lineup of presenters from Tina Kronick and Mike Allen, James McCormick, Tony Nikinchuk, Vinay Prasad, and Victor Montori. They're going to cover a wide variety of topics, including diabetic medications. So many choices, so few options. Dementia update, pediatric rashes, medical cannabinoids, and the perennial favorite, new, true, and poo. PIPE does not receive any industry support, and all speakers are conflict of interest free. So sign up for your individual or clinic rates for an outstanding, almost exclusively virtual, fantastic CV event from the comfort of your home or office. For more information, please see www.pipeconference.ca. Hope to see you in October.
C'est officiel, le FMF 2020 sera virtuel. Du 4 au 7 novembre, participez au plus grand congrès de médecine de famille au Canada. Le FMF offrira plus d'une centaine de séances et ateliers de formation de grande qualité fondés sur les données probantes avec un horaire flexible. Le contenu restera affiché en ligne pendant 30 jours. Cette année, nous vous réservons d'incroyables plénières. Dr Carole Herbert parlera de la nécessité de trouver de nouvelles façons d'intégrer les données probantes dans la pratique, malgré le rythme effréné du monde d'aujourd'hui. Le conférencier professionnel Stéphane Megan s'attaquera à des sujets difficiles pour inspirer en nous la résilience et l'excellence au moment où nous en avons le plus de besoin. Dr Yona Yi donnera ses réflexions sur l'année 2020 qu'elle voit comme le moment de prendre des risques dans la pratique. Durant les 4 jours de l'événement, vous aurez l'occasion d'explorer un hall d'exposition virtuel pour vous informer sur les innovations et les outils en médecine de famille. Et ce n'est pas tout. Vous pourrez échanger avec vos pairs dans notre espace de réseautage en ligne et discuter avec eux des questions importantes. Les tarifs pour participer au FMF seront beaucoup réduits cette année. Vous pourrez vous inscrire dès maintenant au fmf.cfpc.ca. Suivez-nous sur Facebook, Twitter et Instagram.
It's official. FMF 2020 is going virtual. Join us for Canada's largest family medicine conference, November 4th to the 7th. FMF will offer more than 100 top-quality, evidence-based sessions and workshops on a flexible schedule. And they'll be available online for 30 days. This year, we're including some incredible keynote speakers such as Dr. Carol Herbert, who will examine how we have to find new ways to incorporate evidence into practice in our fast-paced world. Professional speaker Stephen Megan will tackle tough issues and inspire resiliency and greatness when we need it most. Dr. Iona Heath, who will share her thoughts on how 2020 is a year of practicing dangerously. Throughout the 4-day event, you'll also be able to explore the virtual exhibit hall to learn about innovations and tools in family medicine. Don't forget to connect with your peers in our online networking space to discuss important topics. FMF is being offered at greatly reduced rates this year, and registration is now open at fmf.cfpc.ca. Connect with us on Facebook, Twitter, and Instagram.
Good afternoon, and welcome to Practical Talks for Family Docs, the College of Family Physician of Canada's live accredited clinical webinar series. I'm Alan Grill, and I'm a family physician from Markham, Ontario. I'm also a part-time physician advisor for the College of Family Physicians of Canada in the Department of Programs and Practice Support. I'm joined today by 3 guests, and I'll introduce each of them now. We have Dr. Meena Dawer, who is a medical officer of health with Vancouver Coastal Health Authority. Among other responsibilities, she supports the immunization, tobacco control, and Healthy Schools program for Vancouver Coastal Health. Dr. DeWer is also a clinical professor with the School of Population and Public Health at the University of British Columbia. She received her MD from Dalhousie University, completed family practice residency training at Queen's University, and a master's in health sciences and public health and preventative medicine residency training at UBC. Dr. Monica Dutt is a settler on Unamaji, the daughter of immigrants and mother to a 9-year-old. She is a public health and preventative medicine specialist and currently the medical officer of health for Central and Western Newfoundland and Labrador. She's a family physician as well at the Ally Center of Cape Breton. Welcome. And finally, Dr. Jennifer Young, a comprehensive family physician in Collingwood, Ontario. She's working in clinic, emergency room, and the hospital. She just finished 2 years as president of the Ontario College of Family Physicians. Congratulations for that, by the way. And during the pandemic, she wrote bi-weekly practical communications to OCFP members, of which I personally found to be extremely helpful. So I welcome all three. And just before we get going, we have some housekeeping issues. I'm going to start with land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The CFPC recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The CFPC respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So our audience today is joining us live on this webinar from either Facebook or YouTube. And in both platforms, you can send questions about the webinar and we'll address them in the second half of the webinar in the last 15 to 20 minutes. For those of you watching on YouTube, please submit your questions in the chat window and our staff will pick them up and send them my way. You'll need to be logged into your own Google or YouTube account. And if you can't see the chat window, you may be in full screen mode. If you're watching using Facebook, you have to be logged into your Facebook account to submit questions in the chat window. Now, today's webinar is accredited for Mainpro Plus credits if you're watching live. So you can get 1 credit, and to claim that credit, you need to complete a short registration form or survey. The link to this survey will be posted in the chat or comments window, likely several times throughout the webinar and as well at the end. And we ask you to complete that by the end of day Friday this week. All right, so before we begin, we usually have to declare our conflict of interest slide, but before we do that, I'll mention my own first. So I don't have any, the relationship I have with financial sponsors are listed here. I have some remuneration for some leadership roles that I have here in Ontario and some conferences that I've spoken at, but I have no relationship with the pharmaceutical industry, and there's no specific funding that's been provided to me for being involved in today's webinar. So I'm now going to call on each of our speakers to declare their conflicts of interest, even though you see them here. So we'll start with Monica.
So no, I have no conflicts of interest.
Excellent. Mina?
Yeah, same, no conflicts of interest.
And Jennifer?
No, I have no conflicts of interest.
Okay, excellent. So just a quick review of how we got here today. So there's been a lot of emerging issues with regards to COVID-19. And we thought it was a good time to have a sort of a second wave webinar to cover several topics. And we're going to cover a few topics today with our speakers. And we're going to start with some questions around back to school. But just before I ask the first question, I just want to make it clear to the audience that this whole pandemic is clearly a moving target. What we say today may change rapidly within the next week or two. So, let's give our speakers a little bit of leeway in terms of the information they're providing, because things are changing absolutely rapidly, which is why we're bringing this webinar to you today. So we're going to start with my first question, which has to do with, we'll start with the learning objectives. So by the end of the activity, participants will be able to recognize the implications of children returning to school during the COVID-19 pandemic, including health and safety protocols, testing recommendations, and symptom management. We're going to list the considerations and challenges of administering the seasonal influenza vaccine during the COVID-19 pandemic. And we're going to determine the initial management of patients presenting with influenza-like illness during the second wave of the COVID-19 pandemic. All right. So the first question that I'm going to ask, we'll start with Mina, and then I'm gonna also want Monica. We're gonna kind of go coast to coast on this one. So Mina, can you describe some of the health and safety protocols that have been implemented in schools in your province when they reopened to help mitigate the risk of COVID-19 transmission?
Mhm. Yeah, so thanks, Alan, for this question. There are health and safety protocols essentially for all jurisdictions and all sectors, including the education sector. So in British Columbia, as required by the Ministry of Education, all school districts and independent schools have to create COVID safety plans for schools, and the COVID safety plans take into consideration the various aspects of safety that we know about, which is essentially trying to distance and space students and staff in space and time, as well as the cleanliness, the symptom screening, etc. These COVID safety protocols were reviewed by the Ministry of Education as well as the local health authorities prior to opening of schools. So that's a basic introduction of what happened here, and maybe I'll just pause in case there's pieces that you want to delve into.
Okay, and Monica, can I ask you a similar question? What schools sort of did in your province, in your neighborhood, in terms of mitigating risk of transmission of COVID-19?
I guess I'd say probably all across the country, the overall framework is probably quite similar. And to be honest, we often look at what BC is doing and then adapt it here. So I think similar to probably everywhere, we look at kind of the hierarchy of controls that can be put in place, which some of you are probably very familiar with, but kind of going from the most effective to the least effective, but still all very important. So going from, the public health measures that are done more broadly, and where I'm working, which I know better actually than where I'm living, Newfoundland and Labrador, that the public health measures have been key, with the idea that we're trying to keep community transmission as low as possible. And right now we have no known cases that are unlinked, that are seem to be due to community transmission. And of course, we'd like to keep it that way, but that's been kind of the primary measure. But then of course you get into the environmental controls. So the cleaning, the barriers, things that can be put up in schools. There's the administrative aspects of it. So that, of course, are things like cohorting and trying to keep a common group of kids together. There's the personal behavior. So that's the kids staying home when they're sick and getting tested. And then lastly, the personal protective equipment like non-medical masks. So I would say everyone probably has similar frameworks that they follow, and every province and territory is using them perhaps in slightly different ways based on what they're seeing in their areas. But that's similar what we've been doing. And I'll say we in Newfoundland and Labrador, because that's where my public health work is based.
No, that's great. And so, we know that the schools have obviously put things in place to help mitigate risk. The next question is for Jennifer. Obviously, I'm sure you get questions, whether it's in your office or the emergency room, from parents that might have concerns about sending their kids back to school. Have there been any resources that you've come across or you've seen developed that might help prepare parents and students to get them ready to return to school, even though obviously they're into it now, but that you saw in preparation for when they returned?
Mm-hmm. Hi, everyone. We are so into this right now. We feel like summer was a long time ago. There was a wonderful resource that was created by one of your colleagues, actually, Alan, that was preparing children for return to school. Dana Abenstein had. I hope we can share the link in the chat box. But it's not this. This is the new guidance around symptom screening. But talking about normalizing going back to school, talking to your children in positive ways, getting them used to wearing masks, getting them used to the concept of distancing, and teaching them how to wash their hands. I mean, just how to wash their hands, the 20-second fingers, thumbs, and doing that regularly, keeping your hands to yourself, coughing into your or sneezing into your arm, wearing a mask, and when you remove your mask, be careful about how you store it and washing your hands afterwards. That resource was something that is very succinct and a lovely resource.
Yeah, no, that's great. I mean, obviously I'm a bit biased because I work with Dana, but she published a blog in Canadian Family Physician as well. We'll share that. We'll link that to the recording of this webinar in case people haven't read it. And what was really interesting about that story is that her husband is actually a teacher. And so they sort of combine their skills of physician and teacher to produce this document. And it's been very well received. So we'll share that link with the audience. Okay, so I'm going to ask Brian, our IT colleague, to just post a slide that actually lists some symptoms related to COVID-19 in kids. Okay, we can leave this one up for now. So there's a lot of symptoms that people talk about with regards to kids. And what I wanted to get a sense of, I'm going to ask each of you to comment on this question. We'll start with Mina in 1 second. In terms of, what symptoms should, influence whether we send somebody, when we send a child for a test for COVID-19. I want to start with Mina because I think it was about 2 weeks ago. It seems like things are happening so quickly. BC was the first province to actually remove some symptoms from their list. And I'm wondering if you can comment on sort of what was some of the science or the policy behind that change. And then I'll call on the other speakers to talk about what's happening in their own provinces.
Yeah, so thanks for that. So it was actually September 11th when the provincial policy was posted. I'm looking carefully at the screen because this is a slightly different portrayal of what we have in BC. So in British, so let's just start with COVID. And of course, COVID can present with a wide variety of symptoms, and that's a whole problem. A large proportion of people have very mild symptoms, including a non-specific headache or fatigue, or just a bit of a sore throat or tickle in their throat. Children in particular tend to have even milder illness than adults in general. And where we wanted to go with this in British Columbia was we knew that children in particular have a very mild illness. A small proportion of illness is in children. Children have a whole variety of other illnesses. We know that in general, less than 3% positivity in British Columbia of all the people who go forward for testing are positive for COVID. It's even lower than that among children. It's about 0.7%. So we were trying to strike a balance between identifying not flooding our testing centers with a whole bunch of kids who were going to have a whole bunch of viruses, and requiring swabbing, and actually picking the tip of the iceberg, those who actually do have COVID, and so trying to strike that balance in a screening test of sensitivity and specificity. So we went with the more specific symptoms such as fever, cough, difficulty breathing, loss of taste and smell. The pieces that we left out were sore throat, runny nose, congestion, headache. So some of the more milder symptoms. Now it doesn't mean that if a child is unwell, they should still go to school. If a child is unwell, they need to stay home for 24 hours so parents can assess, is the child getting better or not? If the child is getting better, doesn't have any of the more specific symptoms, then they can go back to school. If the child, even with milder symptoms, does not get better or gets worse and clearly needs a health assessment. And we were very specific about that term, a health assessment. We didn't want to just say anybody who did not get better in 24 hours needed to get a test, because we wanted to leave it in the hands of clinicians who know their patients best to determine among the whole range of diagnoses that could potentially be responsible for this illness, what is the likelihood that their patient has COVID, and therefore refer them for testing. So we wanted to leave it in the hands of family docs, etc. So again, I'll stop there because I know your question was about science. We really just started with science about screening tests and trying to narrow it down from there.
No, that's great. I'm going to go to Jennifer next because Ontario, literally, it's been less than a week, they also changed some of their guidelines. And I'll ask Brian to put up the next slide. That's the one. So I took this slide from Toronto Public Health, but Jennifer and I discussed it, that this is pretty consistent with most of what's going on in Ontario. So Jennifer, I'm just wondering if you can comment on some of those new guidelines in terms of what symptoms are looked at differently from others and how that's going to impact decisions on which kids should be sent for testing.
Sure, thanks. This slide is a pictogram of the longer document, and I'll just have if Brian can share the link to the 6-page document that describes this. There are some details in that are worth reading. The change is that the symptoms have been divided into two, the top 4 being the more specific ones for COVID-related disease, and then the bottom 5 being ones that are more ubiquitous for general viral infections. And the way that it is worded is if you have a symptom in the high risk, they do. Now I'm going to start by saying the Ontario College of Family Physicians and family physicians in general are quite concerned about this document, because it is referring most of the cases will end up being referred to your family doctor first and not being told to go for a test. When if you do the screening test online is going to refer you to do a test. So though I am in some ways contradicting what Mina has said around the rationale in BC, saying leave it to the family doctor to decide, I think it puts too much burden, and with all due respect, too much burden on family physicians to be the ones to vet that, because there isn't going to be a way for us to say that particular symptom is or is not COVID, and we will always send somebody who has something in that first set of symptoms for testing. The assessment that we would make would be whether someone is so sick that they actually need to go to the emergency room. So apropos of, since the beginning of this whole pandemic, our virtual assessment tool around respiratory illnesses or febrile illnesses, if people are the screening tool will send people with severe symptoms to the emergency room. Otherwise, the screening tool sends people with less severe symptoms for testing. Back to this specific tool, the idea in that second set of symptoms is if you have, say, a runny nose and you don't have to do anything for 24 hours. If it is getting better after 24 hours, you can go back to school when the child feels well enough. If it is not getting better or getting worse, the recommendation on this tool is to call your family doctor or primary care practitioner and for direction. If you have 2 from that second set of symptoms, you are supposed to call your family doctor right away. Don't wait the 24-hour or go for, call your family doctor right away is what this tool says. And as I say, we are trying to get that wording changed because the screening tool that's available online would tell you to go and get a test.
Perfect. Yeah. Yeah, go ahead, Mina.
Yeah, sorry, just a quick add-on. Again, this is the first time I'm looking at the Toronto Public Health framework. It is a bit different than in BC in the sense that I think what they're trying to do is the same as us and not have every kid with every mild symptom to be sent off and referred for a test, which until the availability of a saliva or gargle test was not a pleasant test, let's just put it that way. The other piece that happens in British Columbia is, of course, a 24-hour monitoring period, because many kids will get better within that 24-hour monitoring period and are well enough then to return to school. So again, there isn't that burden towards a primary care system or the testing sites for them to be tested or for the families to have to take them in. And the final piece that I want to say is that we ask for a health assessment, which could be a primary care assessment, or in British Columbia, again, a call to 811, which is our Health Link BC system, where nurse clinicians are available online to provide advice. And really, for the most part, they'll send them for a test. So if kids aren't better in 24 hours, kids are going off for a test. And I'll stop.
No, that's great. And I just want to ask Monica a quick follow-up question. So Monica, Jennifer touched on the fact that if a student is sick with symptoms and gets sent home from school, ends up going for a test, usually if the test is negative and then their symptoms resolve within 24 hours, they can go back. I'm pretty sure across Canada, if a student gets sick and tests positive, there's a 14-day self-isolation period. Where I think there's some confusion that I'd like you to clarify for people is, what happens to the rest of the household members when you have a child who tests positive and is home? Or let's say you have a situation where a child is sick, they're waiting for the results, but they're considered something called like a high-risk close contact. Can you just give some clarification around how things may change in those circumstances?
If I can remember all of those questions. I would want to say first, though, that I think there is variation across the country sometimes on different approaches, and I think it's very much dependent on what's being seen locally, what's being seen provincially, territorially. So I work in a context where right now, in total, we've seen 277 cases. We have no unlinked cases in the province. Almost all of our cases were connected to an outbreak back in April, and pretty much everything has been occasional travel-related cases since. So I think that's a very different context than somewhere where you are seeing a lot of community transmission, and you may treat people who are symptomatic or contacts differently. But at this point, if you are someone who has a high-risk exposure, so you've traveled or you've been in close contact with a known case, you do need to quarantine for 14 days, and there's public health support for that, and we will follow and check in. If a student or if a child who is at higher risk because, for example, they have traveled or been exposed to a known case, as soon as they become symptomatic, then the remainder of their household would also need to quarantine because they would have had contact most likely with that symptomatic child. I know that there are some differences in terms of how people who are symptomatic are being treated across the country, because in some places you are much more likely to be symptomatic with COVID-19 than you might be in Newfoundland and Labrador. So I just caution that sometimes there are different directions for what household members should do rather than what we're doing. So if a child just comes home and is sick, the household does not need to quarantine. If the child has no risk factors, no contact, no travel, the siblings can go to school, the parents can go to work, but that might change if as soon as someone becomes sick, we assume them to have COVID-19 until we've tested and assessed. And in some places that the household also does need to quarantine. So always, check what your local or provincial recommendations are. But right now, that's how we're dealing with it in Newfoundland, Labrador. And the one other variation I'd say is there's some places that do 10 days to being non-infectious to up to 14 days. And we are using 10 days for mild illness, people who seem to have no remaining symptoms. We do use 10 days to consider you non-infectious.
No, that's great. And I think Jennifer wanted to make a comment on this question as well.
Right. So Alan, I'll repeat some of the things that Monica's just said. If you're positive, and this has just been changed, if you are positive and you have mild to moderate illness, you have a 10-day isolation period afterwards, and all of your contacts have a 14-day isolation period after that positivity because of the incubation time added on. If you are under suspicion, so if you had a test and you're waiting, if you're a parent and you have no symptoms, you can go to work. If your child is actually positive, then you have a 14-day isolation period. If your child is a contact of somebody in their school who is positive, you can still go to work. you are not, unless you have symptoms. And if you have symptoms, you need to test and isolate.
Perfect. Yeah, and I think the two key take-home messages from here is always be in good contact with your local public health unit or public health in your province to make sure that what you're doing is in keeping with those guidelines, because there can be some variations in one sec. And it's also probably a good idea to plug the COVID-19 alert app that you can download, which also is a way to sometimes let people know if they've been in contact with somebody else. So we can share that link as well. Jennifer, did you want to add something else?
Yeah, I'd like to make a bit of an editorial comment about the different public health agencies and how confusing it is. I don't think in some ways, and I'll just bring up a most recent example, is Ottawa is saying that that if you have respiratory symptoms, it's 24 hours after symptom improvement, you can go back. But they say for gastrointestinal problems, it's 48 hours. And I'm, you know, that's, I don't know the evidence behind that different recommendation in Ottawa. If it doesn't make sense to me that there would be those differences, such differences between public health units across Ontario, let alone across the country. And I don't think, it just makes things so confusing. I really, and that as part of the Ontario College of Family Physicians, we've really been lobbying for more consistency in messaging and evidence behind the recommendations that are different, because it does not make sense to those family physicians of us who are evidence-based and thinking, well, why is it here this way and why is it this way in another place?
No, it's a very fair point. Monica, did you want to say something else there?
Yeah, I thought I'd just add, thinking about how the screening questions get put together, and a bit more from my medical officer of health perspective, although I'm not speaking as an MOH necessarily, but the fact that there are variations across the country, and I know Ontario, probably within Ontario too, we do have standard questions throughout the province in Newfoundland, Labrador, but just thinking about the things we look at. So we look at, you know, the condition itself and what do we know about it and what do we know about symptoms. And as you all know, you know, the evidence is evolving. There are symptoms that are more common in kids, but as you know, we would have a perfect list, and it's similar across the country if we knew that perfect list. So I think evidence absolutely is being considered in, you know, every symptom on the list. And if you knew some of the, sorry, not you, but if people could see the time that is sometimes spent on each symptom and trying to see what evidence there is and what other provinces are doing. I know sometimes it can be hard though, but just know that the thought that goes into it is significant. There's also the test itself. And so, for example, where we're using right now only the PCR testing right now, the NP swab. So that also influences how we might set up testing. We're looking at things like the gargle and spit and other forms of testing. But right now, that's a factor we need to think about. When is it best? When is it most sensitive? When is it most specific? And when is it most useful? And then the program consideration. So we always have to look at, you know, what capacity do we have? So say in rural small communities, the nurses do home visits. So if you get one school with a whole bunch of sick kids and you have, you know, one nurse is doing home visits for swabs, that might be completely unmanageable. So all of those considerations going into how we set up our screening questions are things that, you know, do occupy a lot of time and effort. And to be honest though, you know, then it gets put out and it evolves, because then you see something you may not have planned for, or things that roll out that you know that either capacity wise or, you know, the burden on families and parents also has to be a factor. So just kind of some context into a little bit about how the lists, as far as I've been involved, can't speak for other places, but how they get put together.
No, that's great. And just to finish off this topic before we move on, Mina, can you just give a quick explanation of how you explain to people or how you communicate what self-isolation truly means? So if somebody is told to self-isolate in their home, what exactly that means and what they should and shouldn't be doing? I think you're on mute.
Yeah, thanks very much. So in terms of self-isolation, it's fairly easy to think of a person, a molecular family, one individual living in their own home, and essentially having their space to themselves and building out from there. So we ask and we expect individuals to live in their space, have their own washroom, have their own cooking arrangement, and essentially for the period of the isolation period, either because they have illness or the incubation period, that they're living in that space and they're not stepping out of that space. Things get difficult, of course, because most people don't live on their own, and they live with a family, or they're sharing a home with several other adults. And in those situations, we try to work with them to get the most optimal isolation arrangement for them, so that they can have a washroom to themselves, and others share another washroom if at all possible, and in terms of eating arrangements, that the family or the support group can organize arrangements so that they essentially don't have to step out of their room for the period of the isolation period. We do allow, clearly people will go crazy, isolated in their rooms for 10 days or 14 days, and I would too. We do understand that, we accept that, and we do allow individuals to step out into their backyard and get some fresh air, as long as they have a mask on, again staying away from their family and their household contacts. But the idea is pretty much they're confining their activities for the isolation period to themselves, and not sharing living or eating space with other contacts. Clearly, they're not going out into the community at all, including work, social contacts, etc.
Perfect. Jennifer, the next question's for you. It's a two-parter, but they're short. So the first part of the question is, should students that get sent home from school because of symptoms require a note from their primary care provider to return to school after they've recovered from their illness, or after they've followed the public health advice on how long they should be at home or self-isolate? And the second part of that question is, can you comment a little bit on work accommodations related to COVID-19 and any guidance you have for primary care providers and family physicians?
Okay. Those are two separate things, really separate things, but thanks. The first one, the answer is no. And that is stated in the Ministry of Health guidelines in Ontario. And I didn't scour through the other guidelines across Canada, but it is stated that doctor's notes are not required to return, nor is proof of a positive test signed by the physician, or the negative test signed by the physician, required. The Ontario Medical Association right now is in the process of designing what we call an attestation form, which can go to will be available to the public, which says I have done X, Y, and Z according to public health guidelines, and it does not require it right now isn't a legal document that's required by the schools, and in fact the guidelines that are there say doctor's notes should not be required for, or should not delay return to school.
Sorry, Jennifer, I think we lost you for a second there.
Oh, okay, sorry. The attestation form is one that is optional. It is not a legal requirement right now. The other, the second component, I'll move on, is I would just say that we have in Ontario, there have been multiple school boards that have been demanding these notes from their patients, and the OCFP has taken the names of those school boards and taken them to the Ministry of Health so that they can then address that with those different school boards that are demanding notes. So I know that it is being asked for. We are doing our best to try to change that pattern of requests, because it is not required in the Ministry of Health and Public Health Ontario guidelines. The next part of the question is around work accommodation. and if you can show the slide, the OCFP created this 2-page document that is on our website that talks about our obligations for work accommodation, and it is consistent with the College of Physicians and Surgeons of Ontario, and we have also had it reviewed by the Occupational Physicians of Canada, who have felt it to be a very useful document that they're going to be making available across their networks as well. So within that document, I won't go in great detail, but it talks about the conditions that might require accommodation and what is being said by various specialty organizations. I won't go into great detail. It's just I would refer you to it, and it can be adapted. You're more than welcome to adapt it if you're the other provincial chapters. So the presidents of the other provincial chapters have taken an interest in this, and many of them are adapting it for if there are adaptations to be made for provincial settings. They are more than welcome to make those changes within it.
No, that's great. We're going to switch gears now to talk a little bit about seasonal.
Sorry, Alan. One of the things that the essence of it is that you need to talk about the restrictions and the limitations that are a part of that person's illness. It's up to the workplace to decide the accommodation. So we talk about, just as we do with disability forms, the conditions and their limitations, but we don't say, and therefore they should have X, Y, or Z in their workplace. It's our role. It is not our role to do the accommodation. It's the workplace to do that.
So it's Mina here, and if I may just step in. So just very quickly, I'm watching the time, and I know, Alan, you're wanting to switch gear to influenza, but just very quickly going back to your first question, which is around notes from family physicians to return to school and return to work. Certainly in British Columbia as well, we've asked that a medical note to assist with return to school is not required at all, and that's been accepted by school districts. The exception is return to work, where if public health excludes people either because they're cases or contacts, and if their employer requires a clearance letter, we will absolutely provide it. I think
yeah, no, I'm having a bit of Wi-Fi issues, so I've just turned off my camera temporarily. Can you still hear me okay? Okay, I'll try to get my camera back on. I just don't want the whole thing to be interrupted. So we're going to shift gears and talk a little bit about the influenza vaccine and immunizing patients against influenza. And Monica, we'll start with you. During the upcoming influenza season, can you just remind people who are at the highest risk of complications? And I think we should encourage everybody to be immunized, but are there certain patient populations that should be highly encouraged to get the flu vaccine this year?
So yes, we've in Newfoundland and Labrador set a goal of 85%. So trying to immunize pretty much close to the entire population. So I would agree with supporting everyone to get immunized. And we've recently shifted. I understand family doctors did in the past in Influenza Labrador, haven't been recently, and now are given the coding and ability to do that again, which is good. The people who we know are at highest risk of influenza are the ones we very much want to ensure are vaccinated. So people who are pregnant, adults, and children with a host of chronic conditions, and I'm not going to name them all. If you ever look up the National Advisory Committee on Immunizations, the statement is there for the 2021 season, and anything you ever want to know would be in there. But things like cardiac or pulmonary disorders, diabetes, cancer, morbid obesity, and then we go into people who are in long-term care and nursing homes and other chronic care facilities, adults over 65, all children 6 to 59. As a group on the list is Indigenous peoples, which is very much more connected to kind of systemic inequities that have made people of Indigenous background more susceptible to influenza. And then the next group are people who are at higher risk of transmitting the virus to others. So of course, healthcare workers. So as always, we encourage all healthcare workers to be to be tested. I have testing in my mind, but to be vaccinated. And then people who live in households with others who are more vulnerable are also important to be vaccinated. And then people who provide childcare to younger children. And then, it kind of ends up covering everybody, because looking at people who provide essential services are another group. But those are the main categories that, if we had to say who are at highest risk or who may be more likely to transmit to people of higher risk, those are the groups that we look at. Should we just talk amongst ourselves now? Oh,
sorry, I'm back. I don't know what's going on with my Wi-Fi today. I do apologize. Sorry to the audience. Okay, I heard most of your answer with regards to the influenza vaccine. So I'm going to ask another question with regards to vaccinating patients, and then we're going to get to the live Q&A. Jennifer, can you talk about some of the challenges and maybe some solutions that are being proposed this year regarding administering the flu vaccine, just given the pandemic and given some of the limitations in our offices, physical distancing? What are some of the challenges and solutions that have been proposed?
Challenges are, we can't put a whole bunch of people in one room waiting for their flu shots. We have to screen ahead of time. We have to clean surfaces afterwards. People need to be having their 15-minute wait period afterwards in a waiting room that has much less capacity. So our flu clinics will not have the same volume that we had before, and they will need to be spread out. They'll need to be pre-booked. There'll be the speaking to people before they come for their flu shots to screen for COVID symptoms. So it does mean that our flu shots will need to take place over a longer period of time, and perhaps more frequently. We are hoping for sharing the load in Ontario. There's a number of different locations that are offering it in different places, and you need to look at your own settings to see what other options are there, such as immunizing through the public health. There are family health teams and community health centers that are having clinics. There are some of for example, our testing center is looking at having a clean and a dirty line for immunizations, flu shots attached to our testing center. There are also the pharmacies. One of the concerns about the pharmacies, in my mind, is that the high dose vaccines are scarce, and we are really trying to lobby for them being available in family physician offices, because those are the ones that should go to the highest risk people in that 65 plus age group. So your patients with COPD, and having part of comprehensive care for those people with COPD is going to be the flu vaccine, and knowing that that's happening within the family physician or the primary care provider's setting is really important. So again, challenges around getting high dose vaccines is another challenge.
Mina, sorry, Monica, your hand was up first, and then we'll ask Mina to comment as well. Go ahead, Monica.
I just had one small comment that there's recently been a statement from NACI, and the National Advisory Committee on Immunizations, around the waiting period. So people might want to look that up, that it can be allowable to have a shorter waiting period post-vaccination. So 5 to 15 minutes, especially when there are constraints around spacing and things like that. But there are certain criteria to be met, so ensuring people are lower risk for a whole range of reasons. But that might be of interest for people to see if you're trying to set up vaccinations within your own clinic space.
No, that's great. And Mina, anything to add?
Yeah, so thanks for asking me to add to this very comprehensive answer. I think it's the piece that I want to say is that it's never been more important for people to be immunized against influenza. It's important every year. It's a severe illness on its own, but in the COVID context, we absolutely want to make sure that everybody has an opportunity to be immunized in order also to decrease the confusion between influenza and COVID. People present with respiratory illness. We've talked about kids. It's hard to determine what their illness may be, and the piece that we clearly don't want is increased activity and increased illness presentation and increased visits to both the testing sites as well as the hospitals, so that the hospitals can truly continue to look after people who are continuing to have COVID or other illnesses, just so that we have the space within the healthcare system to look after COVID, people with COVID as efficiently as possible. That still remains not a vaccine preventable illness, whereas influenza, for the most part, is vaccine preventable or modifiable, so important to do it. And the other thing is that I think all provincial jurisdictions across the country have purchased more influenza vaccine this season than previous seasons. We know, despite the long eligibility criteria in many provinces, individuals you want to focus on, these are your patients, people with underlying medical conditions. Essentially, we encourage you to just immunize anybody and everybody who shows up at your office, and continue to do that safely. Yeah, and thank you for immunizing.
Yeah, no, that's great. Great messaging. Okay, we're going to go to some live questions now that the audience has sent in. So these, they're all on topic, but they don't necessarily flow the same way of the questions we've been asking before. So one of our members of our audience wanted some clarification on something, that if they're working in a clinic, so family physician or nurse practitioner working in a clinic, and they're wearing appropriate PPE in that clinic, is there any reason they should be getting COVID-19 testing if they're asymptomatic? So they're not sick, they're feeling fine, but because they're being exposed to patients, although wearing PPE, is there any reason they should be tested? I'm getting some, Mina, you're shaking your head no.
I see all three of us shaking our heads, and I think that's great, because clearly asymptomatic testing is not recommended for anybody. I know it does happen, particularly in the private lab context for travelers, etc. We know some of the industries in BC, it's a film industry, some of the sports organizations, WestJet, for example, has just announced that it causes more problems than anything else. It's hard to interpret the test. The test is just not reliable when people are asymptomatic. So please don't test anybody who's asymptomatic. There are exceptions made by public health, and we've done that in the context of an outbreak, for example, in a healthcare facility where we do expand our testing beyond those symptomatic, just to see if the virus may be circulating among other residents or patients or staff. But that's a very limited and in the context of an exposure scenario. Outside of an outbreak setting, really there's just no reason for it.
Okay, perfect. Monica, sorry, did you want to comment on that, Monica?
I feel like we could do a whole session on asymptomatic testing. I was just going to add that, again, provinces and territories may have slightly different variations. So as many of you know, we have this so-called Atlantic bubble. And so we run into a lot of issues around people who are constantly needing to quarantine after coming in. So we have instituted some times where people are tested asymptomatically as just one piece of information. So, for example, workers that are going in and out constantly, and at a certain point, they were forever quarantining. So we were trying to find a way that we'd have a little bit more information so that they could have some flexibility in terms of not needing to be, disconnected from the world forever. But the testing doesn't give us, more than that moment in time, but we do use it as part of our risk assessment for after 7 days, not needing to quarantine the entire 14 days. So we have a few examples like that.
And sorry, I'll just say that my apologies to my colleagues across the country. I think the idea here is that each province and each provincial jurisdiction may have a specific question that they're trying to answer, or a specific framework in which asymptomatic testing may play a role. And so I think it's important to stay within that. Clearly in British Columbia, we find that there is a very limited role for testing of asymptomatic individuals, but again, please stay connected with your local public health jurisdictions.
For sure. So Monica, there's actually one follow-up question that somebody asked about. I'll just read it to you, and I'll direct it to you because I think it was based on one of the comments you mentioned earlier. So can you repeat where, I think it might have been the NACI guidelines you quoted about how people can find more information on reduced monitoring time after the flu shot? We can obviously give people the link after this webinar is done, but do you want to just comment on that again?
You know what? I might have, because I have it in my email. So I was just looking. I don't have the link. I have the statement. So I might need to be that might need to be a follow-up because okay. I don't have the link to it. But if you go, I'll check if it's on the NACI site. I don't think it's anything confidential. So I think it should be there, but I just have it in my email. Sorry about that.
It's actually not posted yet, Monica. We were.
Oops, sorry. So you all have this information.
It's not confidential. Certainly the statement was distributed because clearly it takes them a while to get it posted, but it should be getting posted shortly.
Thank you.
Okay. There was another question here that people were just interested in knowing, and all three of you can mention. They were just asking, are there do provinces have the same or different places on where symptomatic patients can go to be assessed? I know that earlier Jennifer mentioned there's the emergency room, there's assessment centers, there's family physician offices. I mean, is it sort of the same type of variety in all three places where you guys work, and it's just a matter of the area and what services are provided there, or are there major differences in the three provinces that you work in? Anyone can jump in.
I'll just quickly start from the West Coast. So we certainly have a lot of testing sites, and those testing sites have expanded over the last 6-7 months. And these are essentially that. They're testing sites, they're not respiratory assessment centers. So we have, so in terms of testing, we have a number of sites. Clearly, people will, with moderate to severe illness, need more than a test. They need an actual assessment of their pulmonary health. And then there's a decision to be made. Do they need to see their family doc? Do they need to go to the emergency department? We have very few respiratory assessment centers in British Columbia, but they do exist by exception.
I can say, and it's different across the province. So I'm not speaking kind of for St. John's area. I've been much more with smaller and rural communities. So we did have both testing sites and respiratory assessment sites combined together. For us, I guess it's a good problem to have. At the beginning of the pandemic, we just did not have the patients coming in, and we didn't have, people who were positive for COVID-19. So eventually they've gone back to testing sites. So you would either get tested through one of the testing sites or a home visit. But yes, if you did need more care than that, that couldn't be done by virtual care by a family physician, then the family physician would need to decide either getting a test and then seeing the patient, or whether that person needs to go to the emergency department. But we are able to ramp up to assessment sites if needed. We just haven't quite hit that point yet that they have been needed.
Okay. Jennifer, anything to add to that?
I can't speak to the rest of the rest of Canada, but I do know that we have been lobbying for assessments, either for testing centers to become assessment centers, though it is very regionally specific. Seeing people with febrile respiratory illnesses in your offices can be done if they have, for example, been tested, because I would say in Ontario, very few family doctors are doing testing in their offices. Just logistically, it's challenging to get the swabs to the right place and get a good turnaround time. So testing is primarily being done in testing centers. But if you choose to see a patient who has a febrile respiratory illness after they've had their swab and before the results are through, you need to be doing so with your full PPE precautions. That would include a gown, face protection, hand hygiene, masking, and doing so with the meticulous cleaning. Book the person at the end of the day, have a specified room that you would use for acute respiratory illnesses, those sorts of public health precautions that will will help to reduce the risk of infection in the clinic. But I would say the evolution of acute respiratory clinics or assessment centers is a work in progress. Hopefully there will be more and more of them as the flu season progresses.
Okay, that's great. So we're coming near the end of the hour, and so I don't have any more time to ask you questions. I think you've answered enough questions for sure to cover this topic. I'm going to give each of you about 30 seconds just to leave the audience with 1 or 2 take-home points, and then we're just going to wrap it up with some housekeeping things. So we'll start again. We'll start West Coast to East. Mina, you start us off.
Yeah, so thanks very much. So very quickly, because we started talking about school-age children, I just want to say that at least in British Columbia, our latest analysis came out yesterday, and one thing we have lots of with this pandemic is, of course, the level of data in the public realm. And fortunately, with the 3 or 4 weeks of schools being in action, we see very little illness circulating in schools. Certainly, there's a number of exposures in school, but we see very little transmission occurring from those exposures. So that's reassuring. I know that there's a lot of concern among educators and parents about that, but for now, things are good. Yeah. Thanks.
Excellent. Jennifer?
This discussion where having public health, medical officers of health, along with their family physician background and myself, it's a really good example of what I think needs to happen on a system level, where public health and primary care and the Ministry of Health need to be on the same page so that there is consistency of messaging. And I just would say that certainly in Ontario and at the OCFP, we've been really trying hard to lobby for that consistency of messaging so that there's less anxiety. There's already so much anxiety that clarity of message is really important.
Excellent. And Monica, you have the last word.
I was trying to think of a good last point. I was thinking about how valuable it's been to work with family physicians in particular and clinicians more broadly. I don't think in my 10-year public health career I've ever worked so closely with the primary care and acute care system, and just how important that is. I'm thinking just one example, there's 2 family doctors in Western Newfoundland that do a video update every few weeks. They get, I don't even know, more than 1,000 views. Like if I tried to do that, I don't think, people don't know me that well. It wouldn't work nearly as well. And so to have trusted voices, both in patient interactions as well as communications, has been key. And I think that partnership with public health is also really important, to have both, the clinical family medicine side as well as sometimes your MOH and public health people who kind of see maybe a whole picture in terms of all the other considerations. I think it's works best when there is that partnership, and it's not always smooth, but I think trying to really strengthen that connection has been so important to the response so far, and will continue to be.
That's fantastic. All right. So just a quick couple of reminders to the audience. To claim your Mainpro Plus credits, please fill out the online survey that will be available until the end of day Friday. And the address is placed on the screen. It was in the chat box. There are a couple upcoming webinars for everyone to mark their calendars. 2 are in French on October 27th. Dr. Jen Chaput is going to talk about demystifying breast cancer, which is a repeat of the webinar that was given in English by Anna Wilkinson recently, as well as on November 16th, Dr. Marcel Arcon is going to give a talk on end-stage dementia. And then the next webinar in English will be on November 17th, Chronic Pain Management with Dr. Mike Allen, Samantha Moe, and Joey Ton, 3 of my colleagues from the CFPC. And finally, just a plug for Family Medicine Forum. It will take place virtually this year from November 4th to 7th, 2020. It welcomes family physicians, teachers, researchers, residents, and medical students from across Canada. The event will offer 4 days of sessions, virtual networking, online exhibits, and posters, and you can sign up and register at fmf.cfpc.ca. And one more huge thank you to my 3 colleagues today. Thanks for taking the time, and thanks for all the hard work you're putting in, both on pandemic issues and non-pandemic issues. I wish you all well and wish everybody stay safe and have a great afternoon.